Dear colleagues, it's a very pleasure for me to be present at your Congress, and many thanks to the ClariVein Society for the kind invitation and merit for support. I'm going to speak about the ClariVein catheter in the treatment of varicose vein, and in particular, my experience and long-term data. I would like to introduce the different treatment modalities in symptomatic varicose vein, starting from surgery. That was for a lot of years the only possibility to treat varicose vein. For a lot of years in the last century, the gold standard for varicose vein. In some patients, the corsectomy could be less invasive with a very little incisions going, but at the end remains the stripper. So I could say that is an invasive technique. And then the thermal technique. But they have two characteristics. First of all, the heat, and the second, related to the first, the need of a two machines anesthesia. So I can say that it's invasive too. And my favorite, the non-thermic technique, the glue, first of all, the newer non-thermic, non-two-machine technique, that is not invasive, yeah. But we don't know, a main question, because we don't know very well the foreign body reaction. So I could say that it's quite invasive. And then there are other modalities such as sclerotherapy, even in association with embolization, and finally MOCA, that with a dual action, with mechanical and chemical action, ablate the vein. MOCA, that means mechanical occlusion chemically assisted, combines two actions. So the mechanical action that creates a damage of the wall to a chemical action with a sclerosin that penetrates in the wall of the vein and create a fibrotic reaction and a secondary thrombus. This is a video of the J-tip of a catheter of a ClariVein at a high speed, creating a great spasm and damage of the wall. Okay, and this is the imaging, the rapid occlusion at the end of a procedure, the rapid occlusion of the vein, as you can see on the left, and the cossus femoral junction on the right, with the epigastric vein that remains open and the occlusion of great saphenous vein. I have introduced ClariVein, and now I would like to speak about myself and my experience in 2012, when my friend, my colleague Andrea Griso was coming back from International Vein Congress. We thought to start using this new method, a new ClariVein catheter. And in 2013, we became one of the first European training center, and in 2014 we started with the first European International training center. And in that years, we remained for a lot of years, not only the first, but one of the few Italian centers using this method. In the same years, NICE reported the lack of evidence in terms of safety and efficacy. While in 2016, it sounds some different, and NICE finally supported the use of ClariVein. And last year, 2022, the European Society for Vascular Surgery recommends, with recommendation grade 2, level A, the use of ClariVein. So a high recommendation with high evidence. And last year, in 2022, there were a lot of users, there were a lot of vein centers in Italy that use ClariVein. And this is my personal experience in 2022. As you can see, I use all the endovascular technique, but I prefer the non-thermic technique with ClariVein almost 50%. Thermic technique, was born more than 20 years ago. The results are very good, for sure, but I think that a modern phlebologist, as you and as me, has to know, has to manage all the endovascular technique. It's not possible to use only one endovascular technique, only thermic technique, because the veins are different. In my opinion, it's not possible to treat a big vein or a very superficial vein or a tortuous vein with the same catheter. So when MOCA, which is the perfect vein for ClariVein, which are the anatomical indication? In 2012, at the beginning of our experience, we believed that it was better to avoid a great tortuosity of the vein, very superficial venous segments, or diameter, little diameter or big diameter. So I think very similar to laser, radio frequency, and other endovascular technique. But now these are my choice. These are my indication. So I prefer to use ClariVein when the vein is very superficial, as in this picture. As you can see, at 2 millimeters from the skin. So very, very superficial, because there is no heat. It's not thermic technique, so it's not dangerous. And with tortuosity, as in this case, because the J-tip is very stable and is very similar to a super catheter. So with this J-tip, is simple to navigate into tortuous vein. And I repeat, ClariVein is very similar at the same time at super catheter and at a guide. And if you wanted to puncture a very little vein, for example, near the ankle, where the vein is little, or for example, a small saphenous vein, distal, very distally, where the distal part where there are not big collateral, but you want to punch this little part, you can easily use a 4 French introducer or an 18-gauge needle, and then use ClariVein. While this is another example where I prefer to perform 2 access, 2 vein access. The first to treat the great saphenous vein above the knee, and the other to treat the vein below the knee, because this is a patient with an ulcer, and with ClariVein it's possible to go to treat the saphenous vein under the ulcer. But which is the great difference with thermic technique, between thermic and non-thermic technique, which is the best quality of ClariVein? And that is a non-thermic technique. So there is no risk of thermal damage, no nerve injuries, and so the possibility to treat the vein below the knee. You know, this is a very strange case. I know it's not so frequent, fortunately, to watch a similar disaster, but it's not so rare. This is a real case. This is a patient that presented in my office last year, treated fortunately in another hospital with radiofrequency. So the thermal damage is possible. But the main characteristics, more interesting difference between thermic and non-thermic technique is the absence of anesthesia. So no two machines anesthesia nor sedation, and makes this procedure a real office procedure. So not the necessity of the anesthesiologist. You can leave your anesthesiologist outside the operative room, and you can go out from operative block that is expensive, and you can you can work more easily in your private office. And the patient wait the discharge after a few hours in this reclining chair. This is a systematic review that compares the non-thermic with the thermic technique, and they conclude that there is no difference in technical success between MOCA and thermic technique, with a significant reduction in pain as well as ecchymosis and hematoma. Instead of thermic technique, a power generator is not required. And so a low initial investment is needed, and so it's useful in your private hospital, office. And what about learning curve? Because someone tell me that it's difficult to manage ClariVein due to the simultaneous movement of pullback injection of sclerosant. But I'm not totally agree. It's not true, because the more important thing is the pullback, while the sclerosant distribute itself. So this is a short video. On the left, you see there is the femoral, the deep vein junction, while on the right, the distal saphenous vein. You can see the movement of the catheter in the right direction. So in the sclerosant, you can see here the sclerosant that go on the right, so not in antegrade direction. It's very, very important. And coming back to the mechanical action, interesting finding was demonstrated in this paper. They used MOCA in 3 groups. So MOCA in the first group, in the second group only sclerosant, in the third group only the mechanical action. And occlusion was seen only in the group treated with MOCA. So it's very important. With the mechanical action that create a channel into the wall, into the deeper layer of the wall, permitting the sclerosant to induce a great chemical reaction in the deeper layers. And the final effect is similar to the famous Swiss cheese, and so it's possible to name this effect the Swiss cheese effect. That is a funny way to remember this technique. And they concluded that mechanical action is a primary endpoint, and pullback speed reduction might lead to a better wall injury. So remember that if you pull back is too fast, you don't treat all the endothelium. And so sclerosant could be similar to only a sclerotherapy. So it's very important, the pullback. And so now you can understand that mechanical action with ClariVein is not the same with other catheters, because the wall injury is not complete, not circular. So while with ClariVein, the J-tip of ClariVein do a circle all around the wall. So the mechanical action is complete all around the wall, and not I repeat, with other catheter, the mechanical damage is reserved only on a line, on a straight line. And what about the result? You know, we started in 2012, and we were the first on the world to publish the result at 5 years. This is the paper published in Journal of Vascular Surgery in 2020, and it includes 395 patients, follow-up for 329 patients. It's absolutely important to highlight the good technical success. We have a problem only in 2 patients due at the beginning of our experience due to a great spasm on the upper part. It's the fastest technique. The average time of the procedure is 12 minutes from the puncture up to the end of the procedure without sclerotherapy or the treatment of collateral vein. We have no major complications, so no pulmonembolism, no DVT. And another interesting thing is that in 1/3 of patients, the grid saphenous vein completely disappeared during follow-up. So during follow-up with Doppler scan, it's possible to watch only a fibrotic line. And these are the complications. In literature, there are no major complications in the majority of reports, except in one case, there were 2 pulmonembolism and 2 DVT, but strange because the pulmonembolism appeared after 1 month from the operation and the DVT on the contralateral leg. So I repeat, it's quite strange. As regards minor complication, includes phlebitis, subcutaneous induration, hyperpigmentation, thrombus progression. Now we experience 7 patients with a thrombus progression, but it's not a problem because it's solved without therapy in a few weeks. And the multivariate analysis in our study, in our report, show that there are no variables influencing the result. But nowadays, I could tell you that probably the big diameter, so an average diameter bigger than 10 millimeters, could represent a limit for this method. Not in this experience, in our experience, because the main diameter was 6.1. The follow-up was 20 months. The anatomic success at 1 year is 94%, at 3 and 4 years, 88%, and at 5 years, 84%. And the cumulative survival-free lymphoid canalization, 92%. But the learning curve changed in protocol after 2 years, and we improved our technique, and we understood that it's necessary to inject the sclerosant as close as possible to the deep vein junction. It's not a problem as regards the thrombus in the deep vein, because the helix effect of the tip rotation drive the sclerosant downward and not antegrade. And the use is standard method. You wash the catheter with saline solution. So you treat the first 6-8 centimeters only with the mechanical action, not chemical action, because you inject the saline solution that remains inside the catheter. So it's not possible. In September 2014, we decided to start with this new protocol. We delivered all the saline solution in the first centimeter. So very quickly, in order to deliver immediately the saline solution, and start with a sclerosant after 3 centimeters from femoral junction. The results are effective. The freedom from recanalization is 92%, while in the second protocol is even better. And if we consider the protocol 2, the anatomic success at 4 years is 92%. And now in this moment, we have changed again. We wash the lumen of a catheter directly with sclerosant. In this way, we think is simple, is more simple to standardize the technique, is more simple to understand. And so we prefer this new protocol. And then we have launched an Italian multicenter study. We are waiting the result at 2 years at the end of September 2023. And finally, ladies and gentlemen, the show must go on. We are studying a new protocol for the bigger vein. Yeah. For the vein with an average diameter more than 10 millimeters, but see you in 2024. So in conclusion, dear colleagues, in my opinion, MOCA is the best in the treatment of small saphenous vein, great saphenous vein below the knee, patient with leg ulcer. In this field, I think there is no competition with thermic technique. I remember that it's possible to start the treatment at 1-2 centimeters from saphenous femoral junction, no worry to a thrombus progression. And the mechanical damage is more important than sclerosant vein volume. And so you think to the pullback and not to sclerosant. Finally, This is a non-thermic technique, non-to-machine technique, so there's no need of anesthesia, no anesthesiologist, no operative room. It means a rapid recovery. So are you asking me why MOCA? You know, Italians do it better. Thank you very much for your attention.